The lateral projection of humerus. First is the patient position. The patient should be erect or standing position, just like this, facing the X-ray tube, and you should internally rotate the arm and flex the elbow at an angle of 90 degrees, and the anterior aspect or surface of the hand will be placed against the hip, just like this, and close contact with the eye. This projection will put the humerus in a lateral position, and the epicondyle should be perpendicular to the IR. Patient should be in supine position, and the posterior aspect of the hand should be placed against the hip. Rest the forearms medially to place epicondyles perpendicular to the plane of the IR. This movement turns the epicondyles in the lateral position without flexing the elbow. When collimating, distal humerus should be included, and elbow joint and the entire length of the humerus. And the placement of the marker, if the left part of the body is being examined, left marker should be used, and if right, then it is right marker. And the IR size is 14 by 17. It depends on the length or the size of the humerus, which IR should you use. And the KBP is 62 because the part thickness is 11 centimeter times 2 plus machine constant, which is 40, is equals to 62 kVp. And orientation is in portrait, and MA is 100, SID is 100 centimeter or 40 inches, and the time is 0.08 milliseconds. This projection will demonstrate the lateral length of the humerus. It will clearly demonstrate the elbow joint and the superimposed epicondyle and lesser tubercle in profile and greater tubercle superimposed over the humeral head. Pathology indicated fractures and dislocation in humerus and traumatic injury into the humeral shaft. Patient is in lateral recumbent. The lateral aspect of the ankle should be placed in contact with the IR or the X-ray table. Dorsiflex the foot so that the plantar surface should be at a right angle to the leg. Adjust the ankle and the foot for a true lateral position, which places lateral malleolus about 1 cm posterior to the medial malleolus. Central ray should be perpendicular to the angle joint entering medial malleolus. Technical factors, collimation. You should collimate the ankle joint proximally and the entire calcaneus, and you should put lead masking into the unused part of the IR to prevent fogging of scatter radiation. And the IR size is 8 by 10 inches divided into half, and it is crosswise. KVP is 60 because the part thickness is 10 cm times 2 equals 20 plus 40 machine constant is equals to 60. MA is 100 and SID is 40 inches. The time is 0.04 milliseconds. And structure shown. This projection will show the true lateral projection of lower third tibia and calcaneus in profile with talus, as well as navicular, and the open joint spaces of calcaneus and cuboid distally. Pathology indicated. This projection will aid in evaluating fracture, dislocation, and joint effusion surrounding in ankle joint and calcaneal fractures. And the central ray should be in the mid, perpendicular to the mid portion of the humerus and to the